Chapter 1. Learning, Applying, and Extending. Motivational Interviewing. William R. Miller Hal Arkowitz. Since the first clinical description of motivational interviewing, M.I. Miller, 1983, research and clinical applications have blossomed like wildflowers. From its original use with problem drinkers, MI is now being implemented in a broad array of other applications including health promotion, social work, psychotherapy, coaching, medicine, dentistry, and education. In this chapter we offer an overview of MI and the ways it has been used in clinical practice, and then we address the evidence base, why MI works, and how clinicians learn it. Motivation in clinical practice and research. The concept of motivation has played a significant role in the history of psychology. Kofer and Apley, 1964, Myers, 2011, Petrie and Govern, 2012, though this scientific knowledge base has seldom been applied in psychotherapy. The concept of motivation is particularly pertinent when clients seem stuck. A traditional therapeutic view is that such stuckness represents resistance to change. Clients are sometimes said to be resistive, oppositional, or in denial, terms that have a pejorative connotation. 2. Motivational interviewing in the treatment of psychological problems. Implying pathology and willful, even if unconscious, obstruction of the therapist's benevolent efforts. Schools of psychotherapy have had different views on the nature and origins of resistance and how to work with it. Focusing instead on the psychological dynamics of motivation can invoke a more positive emphasis on how and why people do change and how therapists can facilitate it. Engel and Arkowitz, 2006, Miller, 1985. Social psychologist Kurt Lewin, 1935, described various motivational conflicts, such as approach, avoidance, whereby people can be immobilized by ambivalence. Rather than being a pathological phenomenon, ambivalence is a normal and common human condition whereby people simultaneously want and do not want something. Clients who seek therapy are often ambivalent about change, and their motivation may ebb and flow during the course of treatment. MI is a method for helping clients to get unstuck and resolve such ambivalence in favor of positive change. Within the trans-theoretical model of change, Prochaska and Norcross, 2013, ambivalence is a normal process on the road to change. In fact, ambivalence, the contemplation stage, is a step forward from the earlier pre-contemplation stage, where change is not even being considered. Many therapies and therapists are prepared to help clients who have already progressed 2 steps further to the action stage, but what about those who are not yet ready for change? In addiction treatment, such clients were once told to go away and come back when they were motivated. That's not good enough. Helping people to work through ambivalence and readiness for change is an important therapeutic skill, enabling one to work with a broader range of clients than just those who are already sufficiently motivated. Now, consider the interpersonal dynamic when a client who is ambivalent about change sits down to talk with a therapist who wants to promote change. Miller and Rolnick, 2013, have described a natural writing reflex of professional helpers to educate, persuade, and advise clients about change. Doing so takes up one side of the client's ambivalence, the pro-change side. A predictable result is for the person to then respond with the other side of ambivalence, yes, but. If the therapist reciprocates with counterargument, he or she has thereby in essence externalized the person's ambivalence, with the clinician advocating for change while the client argues against it. There are both theoretical and empirical reasons to be concerned that this pattern is countertherapeutic, actually decreasing clients' commitment to change. Daryl Baim, 1967, posited that, from a conceptual perspective, learning, applying, and extending MI3. People learn what they believe in the same way that others do, namely, by hearing what they say. If a non-coercive context, such as counter-attitudinal role play, causes them to defend a particular position, they become more committed to that position. Baim's self-perception theory offered an alternative explanation for the large literature on cognitive dissonance, Festinger, 1957. It is also clear that external pressure can undermine the desire to change. Brehm and Brehm, 1981, adduced that an aversive state of reactance arises when people perceive a threat to their behavioral freedom. One motivational response is to intensify one's attitudes and behaviors in opposition to the persuasion or coercion. Empirical evidence can be derived from studies of psycholinguistic processes in MI. In spontaneous speech, clients' ambivalence is represented by the balance of change talk, verbalizations favoring change, and sustained talk, favoring the status quo. The ratio of change talk to sustained talk during treatment sessions predicts the likelihood of subsequent behavior change. Moyers, Martin, Houck, Christopher, and Tony Gahn, 2009. This finding parallels similar ones from the trans-theoretical model that movement from contemplation to action is signaled by an increase in the pros relative to the cons of change. Prochaska, 1994. This relationship might be of only passing interest. Motivated people are the ones who change, were it not that levels of client change talk and sustained talk or resistance are strongly influenced by therapist responses, as demonstrated in both correlational, Berthollet, Fauci, Gmel, Gaume, and Dapin, 2010, Dapin, Berthollet, Gmel, and Gaume, 2007, Gaume, Berthollet, Fauci, Gmel, and Dapin, 2010, Moyers and Martin, 2006, Moyers et al., 2009, and Experimental Studies, Glynn and Moyers. 2010, Miller, Benefield, and Tony Gahn, 1993, Patterson and Forgach, 1985. Thus, if therapists counsel in a way that evokes more sustained talk or resistance than change talk, clients are less likely to change. In contrast, change is promoted by differentially evoking from clients their own change talk. Related findings from social psychology are found in the literature on decisional balance. As mentioned above, a person's balance of pros to cons, a passive measure of decisional balance, reflects readiness for and probability of change. As a clinical procedure, however, decisional balance involves actively evoking and exploring all the pros and cons of change, thus causing clients to voice both change talk and sustained talk. Clinical studies indicate that doing this with people who are ambivalent consistently decreases their commitment to change. Miller and Rose, 2015, perhaps by perpetuating rather than resolving ambivalence. For motivational interviewing in the treatment of psychological problems. What is MI? MI is a particular way of having a conversation about change so that it is the client rather than the clinician who voices the arguments for change. Miller, 1983, Miller and Rolnick, 2013. It is strongly rooted in the person-centered approach of Carl Rogers, 1951, 1959, 1980, in its emphasis on understanding the client's internal frame of reference and concerns. In both MI and client-centered counseling, the therapist provides the conditions for growth and change by communicating attitudes of acceptance and accurate empathy. MI can be thought of as an evolution of client-centered counseling. It differs from a classic non-directive approach in that there is clear direction toward one or more specific outcome goals, and the therapist uses systematic strategies to move toward those goals. Usually it is the client who brings the change goals, although in certain contexts, such as addiction treatment or probation, the clinician may by role have change goals that the client does not necessarily share, at least at the outset. For processes of MI. MI is now described as comprising 4 processes. The first of these is engaging, developing a therapeutic alliance that facilitates working together. Client-centered counseling skills are prominent here from the very beginning. A second process is focusing, clarifying the goals and direction of counseling. With a clear goal in place, the evoking process involves eliciting the client's own motivations for change. It is here that the therapist attends in particular to the client's change talk, seeking to evoke, understand, reflect, explore, and summarize it. When there seems to be sufficient readiness for change, MI proceeds to the fourth process of planning. Though the 4 processes sound linear, in practice they are quite recursive. One may double back from planning to evoking if motivation seems to wane. It is common for the focus of consultation to change, and at times it is important to strengthen engagement. Somewhat different skills are involved in each process, though the client-centered engaging skills form a foundation throughout MI. Underlying spirit of MI. There is also strong overlap between a person-centered approach and what the co-developers have described as the underlying spirit of MI. Learning, applying, and extending MI5. Miller and Rolnick, 2013, Rolnick and Miller, 1995. Without this larger mindset and heart set in practice, MI can be confused with and reduced to a set of techniques. Accurate empathy has been a key element in MI from the start, Miller, 1983, and is linked to therapeutic efficacy, Moyers and Miller, 2013. Empathy is central to the first of four fundamentals of the spirit of MI, acceptance, which also includes honoring client's autonomy, affirming their strengths, and respecting each person's absolute worth as a human being. A second component of MI spirit is an attitude of partnership, a collaboration between the clinician's expertise and client's own expertise about themselves. The component of compass shown is the intention to give primacy to the client's own welfare, growth, and best interests. Finally, evocation is the mindset of calling forth the client's own wisdom, values, ideas, and plans. Evocation is the opposite of a deficit model, that the client is lacking something that the therapist needs to install. Rather than communicating "I have what you need, and I will give it to you," the underlying message in MI is "you have what you need, and together we will find it." Compatibility with other methods. MI was never intended to be a comprehensive psychotherapy. It is a therapeutic tool for addressing the common issue of ambivalence about change. Miller, 1983, first conceptualized it as a prelude to or preparation for treatment, and a surprise in early studies was that after MI clients often proceeded to change their drinking on their own without seeking further treatment. Miller et al., 1993, Miller, Sovereign, and Craig, 1988. Thus MI is sometimes practiced as a freestanding treatment, often as a brief opportunistic intervention. More commonly though, MI is being combined with other treatments such as cognitive behavioral therapies, Longabout, Zwiebin, LaCastro, and Miller, 2005. A meta-analysis found that MI had the most enduring effects when it was combined with another active treatment, Hetima, Steele, and Miller, 2005. In one common adaptation known as Motivational Enhancement Therapy, MET, the client is given personal feedback based on individual results from standardized assessment measures, Wall, Todd, et al., 2007. Miller, Zwiebin, Diclement, and Richterich, 1992, Stevens, Baber, Cadden, and Miller, 2002. This feedback, which concerns the client's level of severity on target symptoms compared to norms, is delivered in an MI style. MET may be particularly useful in working with clients at a pre-contemplation level who perceive little or no reason to change. Miller and Rolnick, 2013. 6. Motivational interviewing in the treatment of psychological problems. Basic engaging skills of MI. For clinical microskills derived from client-centered counseling are used throughout MI, abbreviated by the mnemonic acronym OARS. The O component is to ask open questions that give clients latitude in how to respond. Often intake interviews consist of a long litany of closed, short answer questions that leave the client in a fairly passive role. I ask the questions, and you give me the information I want. Carl Roggers's tongue-in-cheek skepticism about assessment was that it's of limited use because the client already knows all this. Beyond the asymmetrical power relationship of question and answer, this approach also implies that once you have enough information, then you will have the solution. MI generally avoids this expert role, where the therapist pretends to know more about clients than they do themselves. If change is to be integrated into people's daily lives, their own expertise about themselves is a vital resource. There are also informal guidelines to limit questioning, such as not to ask 3 questions in a row, even open questions. A is for affirming. In MI, clinicians watch for and affirm clients' strengths and abilities. Each step in the right direction, no matter how small, is recognized and affirmed. Clients are often asked to describe their own strengths, a self-affirmation process that tends to strengthen therapeutic alliance and reduce defensiveness. Rather than focusing on pathology or criticizing shortcomings, the clinician seeks to catch people doing something right. This affirming of strengths and efforts is consistent with communicating positive regard. Some simple examples of affirmations are "it took courage to do that," and "that's a really good idea." Perhaps the most frequently used micro-skill in MI is reflection, a key method for experiencing and communicating accurate empathy. Simple reflections repeat all or part of what the client said. Though helpful at times, they are quite limited and often feel unnatural. Therapeutic. Momentum is much better promoted through complex reflections that make a guess about what the person means, but has not quite said yet. One way to think about this is continuing the paragraph, not repeat what the client has just said, but instead saying what might be the next phrase or sentence in the paragraph. The goal is to understand clearly how clients are experiencing their reality, and to reflect that understand back to them in a way that encourages continued experiencing. Many therapists learn about reflective listening as part of their early training in basic interviewing skills. It is easy to underestimate the difficulty of skillful empathic reflection. High-quality reflective listening is a learning, applying, and extending MI7 core skill in MI and in the person-centered approach more generally. The majority of responses from a skillful MI practitioner should be reflective guesses about the client's meaning. It can be a challenge for novices, as well as experienced professionals, to rely primarily on empathic reflect-in rather than asking questions, offering advice, and relating in other ways that impose an external frame of reference. Finally, the S in OARS is a reminder to summarize. Summaries play an important role in client-centered counseling, and have more particular uses in MI. They not only show that you have been listening and value what clients say enough to remember it, good summaries also link material together and can help emphasize certain points. Beyond the OARS, MI includes a particular way of offering information and advice when appropriate. The most general guideline is to offer information or advice with permission and not tell clients what they already know. A client may ask you for suggestions. What do you think I should do? And you can ask directly for permission. Would it be helpful if I told you some things that other people have done that worked for them? Such offerings in MI are often accompanied by autonomy supporting statements like "you may or may not agree," or "I don't know whether this will concern you or not. It's up to you, really." Rather than downloading an uninterrupted sequence of information, the interviewer offers it in small chunks, checking in regularly for the client's own responses and perceptions, a sequence that Rolnick has termed elicit, provide, elicit, Rolnick, Miller, and Butler, 2008. Focusing. Sometimes the focus for conversations about change is set by the context. A person who walks into a smoking cessation clinic does not wonder what the topic of conversation will be. In more general health and social services, it is usually the client who offers presenting concerns to be addressed. Then there is the situation where the clinician has a focus or concern that the client may not share. Brief opportunistic interventions are of this kind. A patient comes to a clinic wanting relief from a cough and sore throat, and the physician wants to talk about smoking. Probation officers and disciplinary administrators regularly enter into conversations about change with less than eager participants. Many clients are referred to addiction treatment services by the courts or relatives and offer mostly sustained talk at the beginning. MI can be used in any of these circumstances to move toward an identified goal. The focusing process is 8. Motivational interviewing in the treatment of psychological problems. To identify mutually acceptable goals. When a change goal is prescribed by the context or a client is ambivalent, a challenge is to find the client's own motivation to move toward that goal. That is the process of evoking Evoking. Evoking is the process that is most unique to MI. Having identified a clear focus for the conversation about change, the clinician proceeds to steer the conversation toward finding and exploring the client's own motivations for change. This involves 3 sets of skills for recognizing, eliciting, and responding to change talk. This is not to say that sustained talk is ignored or disrespected. When a client offers sustained talk, as happens naturally in ambivalence, the clinician listens to and often reflects it. It is interesting that sometimes when you reflect sustained talk, the client responds with the other side of ambivalence. Consider this actual exchange. Client: I really don't think alcohol is a problem for me. Interviewer: drinking hasn't really caused you any problems. Client: well, it does. Anybody who drinks as much as I do is bound to have some problems. The MI clinician, however, is particularly interested in finding and exploring change talk and usually does not go looking for sustained talk, as one might do in a decisional balance intervention. This emphasis requires, first, being able to recognize change talk when you hear it, and, second, realizing that, of all the things clients say to you, this is particularly important material because it predicts change. Recognizing change talk. So, what is change talk? In the most general sense, it is anything clients say that signals a move toward or openness to change. You already know much about this just by virtue of being a member of society. When you ask someone to do something, you pay particularly close attention to what he or she says in response to your request, because the person's words contain 4 types of preparatory change talk are abbreviated in the acronym DARN: desire, ability, reasons, and need. Every language on earth has a way of saying I want. Goddard and Wiersbicka, 1994. Desire statements imply an approach motivation: I want, like, wish, prefer, and the like. I want to feel less anxious. I would like to lose some weight. I wish I were more comfortable talking to people. Ability statements imply the possibility of change. I know I can be kinder to my wife. I am able to resist temptation sometimes. I could just keep my mouth shut. Reason statements have an if, then quality, expressing a desirable outcome if the change were made or an undesirable outcome without change. If I get arrested again, I'll lose my job. My kids would be happy if I didn't criticize them so much. I should take my medication so I can concentrate at work. Finally, need statements have an imperative quality of must, have to, need to without necessarily stating a reason why. Something has got to change in our relationship. I have to get over this performance anxiety. I need to have a better relationship with my kids. Other kinds of statements are called mobilizing change talk because they signal movement in the direction of change. An acronym here is CATS: commitment, activation, and taking steps. 10 Motivational Interviewing in the Treatment of Psychological Problems. Commitment language is how we make promises and agreements. In a way, the strongest committing speech is also the simplest: I will. I do. I promise. There are also endless subtleties to signal greater or lesser degrees of willingness. I probably will. I promise, I guess. I guarantee that I will. Then there are activation statements that are not quite commitment, but do signal willingness. I'll consider it. I'm willing to. I might. Taking steps statements refer to something the person has already done to move toward change. This might occur when a client returns for the next session and says, I bought a pair of running shoes this week, with the goal of exercising more. I filled the prescription you gave me. I did the diary that you asked me to keep. I went 2 days without smoking this week. Change talk matters because it presages change. It literally is clients talking themselves into change. Miller and Rolnick, 2004. Some good news is that it is not the client's level of change talk and sustained talk at the beginning of a session that predicts change, or the lack thereof. Rather, it is client speech toward the end of an MI session, and the pattern over the course of the session. Amrine et al., 2003. During a successful MI session, the balance of change talk to sustained talk gradually shifts. In an experimental design, this balance rises and drops as the counselor shifts back and forth between MI and a more directive method, Glynn and Moyers, 2010. Sustained talk is simply the opposite of change talk. It consists of statements that reflect an inclination toward the status quo and away from change. If the topic were whether to begin exposure-based treatment for post-traumatic stress disorder, PTSD, a client might say, Learning, applying, and extending MI 11. I really don't want to do it. Desire, I can't do it. Ability, it would bring up all of those memories for me again. Reason, I don't need to do it. Need, I'm not going to do it, period. Commitment, I'm not ready. Activation, I cancelled my appointment. Taking steps. With people who are ambivalent, it is normal to hear both change talk and sustained talk together, even in the same sentence and often with a but in the middle. I want to change talk, but I don't think I can do it, sustained talk. I'm not very happy about it, sustained talk, but I need to change talk. It's not what I want to do, sustained talk, it's what I'm going to do, change talk. The key to recognizing change talk is to tune your ear to hear it so that it stands out in your perception whenever it occurs. Eliciting change talk. You don't have to wait for change talk to occur, though with ambivalent people you're likely to hear it regardless. There are evoking skills that invite clients to express change talk. Perhaps the easiest and most common way to elicit change talk is to ask for it with an open question. This involves thinking one step ahead. If I ask this, what is the client likely to answer? Consider the expected answers to these open questions. What are some good reasons for you to make this change? Change talk, why haven't you done it? Sustained talk, knowing what you do about yourself, how might you be able to do it? Change talk, what do you like about how things are now? Sustained talk. Ask open questions, the answer to which is change talk. Another evoking strategy involves looking ahead, asking clients. 12 Motivational interviewing in the treatment of psychological problems. What could be the advantages of making the change, and what might happen if they continue on their present course? Exploring hopes and values also can be useful. How would you like for your life to be different a year from now? What is the worst that might happen if you keep on as you have been? What do you care about most? How would you like to be remembered? A simple scaling question is to ask on a scale from 0 to 10, where 0 is not at all important and 10 is the most important thing in your life right now. How important would you say it is for you to? The client offers a number, perhaps a 4. Which would be the better follow-up question? And why are you at a 4 instead of 0 or 1? And why are you at a 4 instead of a 6 or 7? The answer to the former is likely to be change talk, whereas the answer to the latter would probably be sustained talk. These are just a few examples of ways to evoke change talk. There are hundreds of ways to do it, and you get immediate feedback from your client as to whether you're doing it well. Responding to change talk. When you hear change talk, don't just sit there. If you respond in particular ways, you are likely to hear more change talk. For those 4 ways there is yet another acronym, EARS. Actually, EARS is just OARS with the first letter changed to an E because it is a specific type of open question, one that asks for a lab tie-in, or an example. If a client were to say, I think I would feel better if I exercised more, an E response could be, in what ways do you think you would feel better? When have you felt good after exercising? Give me an example. How do you think exercising more might help you? All of these encourage the client to keep exploring the change talk theme that was just offered. Ask such questions with curiosity and a desire to understand better what the person means. Learning, applying, and extending MI 13. A again is for affirm. You can offer a statement of appreciation or encouragement in response to change talk. Good for you. That sounds like a good idea. You really want to stay healthy. Perhaps the most natural response to change talk is to reflect it. This again encourages the person to keep exploring and elaborating on the change talk. Client, we just never talk. We don't communicate. Interviewer, you'd like to be communicating better. Simple reflect tie-in, client, yes. Sometimes we go for hours at home without saying anything. Interviewer, that sounds kind of lonely. Complex reflection. Client, well, it is. I feel like he takes me for granted. Interviewer, and you would like to feel closer and cared for. Complex reflection, continuing the paragraph. Client, isn't that what a marriage is all about? Interviewer, it's really important to you, important enough that you're willing to work on it. Trying out some additional change talk. Client, I am. In general training on empathic listening, there is often little guidance about what to reflect out of all that a client says. In MI, it is particularly important to hear and reflect the client's change talk. Similarly, although summarizing is often taught as a basic counseling skill, there are usually few guidelines about what to include in a summary. In MI, one is first listening for and evoking change talk and reflecting it when it occurs. As change talk accumulates, the clinician offers summaries that pull it together. Each bit of change talk is like a flower, and the interviewer is assembling a bouquet. After hearing 2 or 3 flowers, offer back a small summary. So far, you've said that you would like to be communicating better in your relationship, and you wish you would spend more time together doing fun things instead of just the routine. How else do you think you might strengthen your relationship? 14. Motivational interviewing in the treatment of psychological problems. The open question invites more flowers, and as they come the bouquet grows larger. When you sense that you have collected all the change talk that is readily available, you can offer a recapitulation summary that pulls it all together. Thus, clients first hear themselves expressing change talk, then hear it again as you reflect it, and then hear it again in summa rise alongside their other change talk. This is a path out of ambivalence, and one that is more difficult to do alone, when self-talk tends to vacillate between change talk and sustained talk that negate each other. Planning. The fourth process in MI is planning, developing a specific plan for how to implement change, or at least a first step. Clients often signal you that they are ready to begin the planning process by offering more mobilize ing change talk and less sustained talk. You can test the water by offering a recapitulation summary of change talk, and then asking a key question, the essence of which is so, what next? Given what you've said so far, what do you think you ought to do? So, what are you thinking at this point about how to proceed? If you do want to move in this direction, what might be a good first step for you? Perhaps the main point about planning in MI is that you are still evoking the plan from the client, drawing on the person's expertise. The MI style encourages a change plan that comes primarily from the client rather than the therapist. Switching into a directive mode at this point can undermine the motivational progress that has been made. As stated earlier, it is fine to offer some information or advice with permission, but beware of uninvited advice. What is the person ready, willing, and able to do? You may encourage the client to think about change with questions like, how do you think you can make that happen? At times, clients may be motivated to change, but not know what they need to do in order to accomplish the change, example, to reduce panic attacks. At such times, your own expertise is a useful and necessary part of therapy. The issue isn't whether or not advice and suggestions are offered, but rather how and when they are offered. In MI, this input is given by a therapist, who assumes the role of guide or change consultant. A guide doesn't decide when or where you should go, but instead helps you get to where. Learning, applying, and extending MI 15. You want to go. If the client wishes, you may make suggestions about various possible ways to proceed, with the attitude that the client will choose those options that fit best at present. For example, a therapist might say the following to a client who appears ready to change, but doesn't know how to do it. I have some thoughts about approaches that have been helpful for other people with a similar problem. Would you be interested in hearing them? In this way, the therapist conveys respect for the client's ability to choose what's best for them, while being ready to provide input to facilitate change. We should note that people often vacillate in their degree of motiva tie-in and ambivalence within and across sessions. As Mahoney, 2001, suggested, change is best described as an oscillating process. It is seldom linear or unidimensional. Most people who seek therapy have more than one concern, or are weighing change at various levels. For example, depression is often accompanied by relationship problems and substance abuse. There may be different degrees of motivation for change in these different problem areas. In addition, Arkowitz and Burke, 2008, and Zukov, Swartz, and Grote, Chapter 6, this volume, distinguish between motivation to change the overall problem, example, anxiety, and motivation to engage in the actions necessary to accomplish the change. A person highly motivated to decrease distress may nevertheless be unwilling to pursue a particular strategy for doing so. There may be ambivalence about one or both of these. It is normal for there to be multiple goals. More than half of those with a diagnosis of either an anxiety or depressive disorder meet the criteria for at least one additional anxiety or depressive disorder. Brown, Campbell, Lehman, Grisham, and Mansell, 2001. With substance use disorders, as with many others, comorbidity seems to be the rule rather than the exception. Miller, Forsheims, and Zwiebin, 2011. Clients may be at different stages of readiness for change in each problem area. A CLI ant might be highly motivated to work on his or her anxiety disorder, but disinclined to change his or her substance use. Fortunately, therapeutic change in one problem area is often associated with improvement in other problem areas. Newman, Przeworski, Fisher, and Borkovec, 2010. Resistance. In the first two editions of Motivational Interviewing, Miller and Rolnick, 1991, 2002, the concept of resistance was prominent. In fact, during the first decade or two, a common motivation for clinicians to seek 16 motivational interviewing in the treatment of psychological problems. MI training was the unanswered question: how can I deal with my most resistant and difficult clients? The third edition, Miller and Rolnick, 2013, signaled a significant shift away from the concept of resistance, which as noted earlier has somewhat pejorative overtones that imply it is a client problem. Two findings prompted this movement away from resistance. The first was abundant evidence that the behavior termed resistance is highly responsive to therapist style. It can literally be dialed up or down by changes in therapist response. Glynn and Moyers, 2010, Patterson and Forgach, 1985. It takes two to resist. Secondly, it became clear that most of what had been described as resistance was merely sustained talk, a normal manifestation of ambivalence. If one subtracts sustained talk from resistance, what is left? Miller and Rolnick, 2013, termed it discord, behavior that signals dissonance. In the therapeutic relationship, unlike sustained talk, which is about the change target, discord statements often contain the word you. You don't understand how hard it is for me. You can't tell me what to do. I'm not sure if you can really help me. You're not listening to me. Both sustained talk and discord are highly responsive to therapist style, and high levels of either predict a lack of change. Both sustained talk and discord are important and warrant your notice and response. Our clinical experience, however, is that if you start with an MI style from the beginning, you are unlikely to encounter much discord along the way. Sustained talk will still be there, of course, because it is normal with ambivalence, but as MI proceeds, sustained talk tends to wane while change talk increases. Neither is sustained talk or discord necessarily a product of client pathology. Both are clearly responsive to interpersonal dynamics. Relationship of MI to other psychotherapies. MI is more of a way of being with people than it is another school of therapy. Rogers, 1980. Yet, as in other types of psychotherapy, the goal is to facilitate therapeutic change. In this section, we will compare and contrast MI with other psychotherapies and briefly discuss how MI can be used in conjunction with these other therapies. Learning, applying, and extending MI-17. While MI is strongly rooted in Carl Rogers's client-centered therapy, it also shares similarities with other therapeutic approaches. MI and psychoanalytic therapies view ambivalence, or resistance, as meaningful information that can be used productively in therapy. However, they differ sharply in the types of information that they consider important and how they respond to it. In psychoanalytic theories, resistance is usually thought of as conflict, mostly unconscious, between the client and therapist. A central construct in psychodynamic theories and therapies is transference, the unconscious tendency for the client to assign to the therapist feelings and attitudes associated with the client's early significant and problematic relationships, especially with parents, early in life. In this context, resistance provides clues to repressed conflicts that are carried over from the past, and reenactment in therapy allows the therapist to help the client resolve the resistance and the early conflicts associated with it. By contrast, MI is almost entirely focused on the here and now, without a priori views about why ambivalence occurs. Ambivalence and discord are not seen as reflecting pathology. In MI, what is important is to understand the client's perspective and evoke his or her own motivations for change. In cognitive behavioral therapy, CBT, ambivalence is seldom discussed and is not given any special status, though some behavior therapists, example, Patterson and Forgach, 1985, and cognitive behavioral therapists, example, Leahy, 2002, have addressed resistance. A behavioral perspective attributes resistance to the therapist's inadequate conceptualization of the conditions that control the behaviors. Cognitive therapists, example, Beck, Rush, Shaw, and Emery, 1979, regard resistance as providing information about a client's distorted thinking and beliefs. For example, when a depressed client in cognitive therapy doesn't comply with homework assignments, cognitive therapists search for the beliefs and schemas that may be causing the resistance, such as pessimism about change. In contrast to MI, CBT is a fairly didactic approach that emphasizes teaching clients new behaviors and ways to correct dysfunctional beliefs. CBT operates largely from a deficit model, implying that the client's problems emanate from something that is missing, example, skills, rational thinking, appropriate contingencies, that the therapist can teach. The use of the phrase homework assignments in CBT highlights the role of the therapist as more of a teacher in the change enterprise. The CBT therapist is regarded as an expert who can provide direction for the client in facilitating change. By contrast, MI involves more of an equal partnership than an expert-patient relationship. 18 Motivational interviewing in the treatment of psychological problems. MI has the potential for enhancing the effectiveness of CBT and other therapies. MI can provide a context for integrative therapy and the use of cognitive behavioral methods, Arkowitz, 2002, Engel and Arkowitz, 2006, Miller, 1988. Strategies of both cognitive behavioral and psychoanalytic therapies, such as structuring between session activities in the former and giving interpretations in the latter, can be conducted in the context of a relationship that is more congruent with MI rather than in a manner that is more expert-driven. With the benefits of accurate empathy and evoking clients' own motivations for change, MI has the potential to enhance the efficacy of other active treatments. How effective is MI? How well does MI work, for what, and for whom? Across 4 decades, a large body of research has accumulated to answer these questions. We summarize this literature here in 3 sections. 1. The efficacy of MI in clinical trials. 2. The relative efficacy of MI when compared with other approaches. And 3. Studies of clinical effectiveness. How well the method holds up in community practice, outside the controlled conditions of clinical research. The MI website includes a cumulative bibliography RAFI of this literature. See www.motivationalinterviewing.org. Efficacy trials. Randomized clinical trials are often considered to be the gold standard in demonstrating treatment efficacy. In these studies, participants agree to be randomly assigned to receive different treatments, such as MI or a comparison condition. Those in the comparison condition may receive no treatment, be placed on a waiting list, or receive treatment as usual or a different type of treatment. As we completed this chapter, more than 200 randomized clinical trials had been published for interventions identified with MI, along with many reviews and meta-analyses summarizing research findings. Britt, Hudson, and Blampede, 2004, Heckman, Eggleston, and Hoffman, 2010, Hetima et al., 2005, Lundahl et al., 2013, Lundahl, Koons, Brownell, Tollefson, and Burke, 2010, Rubach, Sandbeek, Lauritsen, and Christensen, 2005. Several general conclusions may be drawn from this literature. There is strong evidence that MI can be effective in triggering behavior change, with average effect size generally in the small to medium range across a wide variety of target problems. Another clear pattern is learning, applying, and extending MI-19. High variability in the efficacy of MI across studies, therapists, and sites within multi-site trials, related in part to the quality or fidelity of MI that is delivered. Miller and Rolnick, 2014. The outcome literature ranges from null findings to large effect sizes, suggesting that other unidentified factors may mediate or moderate the efficacy of MI. As with many psychotherapies, the specific effect of MI tends to diminish with the length of follow-up. An interesting exception is that MI has continued to show a sizable effect, 0.6, that holds up over time when MI is added to another active treatment. Hetima et al., 2005. MI and other treatment methods seem to have a synergistic effect. MI may increase the efficacy of other methods by enhancing adherence, and the efficacy of MI benefits from the additive effect of adhering to another active treatment. In many such studies, MI was used as a pre-treatment to another therapy. Some studies have found that the effectiveness of MI is greater with clients who have more severe problems. Example, Handmaker, Miller, and Manick, 1999, Westra, Arkowitz, and Dozois, 2009. Relative efficacy of MI. What happens when MI is compared directly with other treatment methods? Here, MI is not added to another approach, but instead clients are assigned at random to receive MI or a different treatment. Across STUD IES, people receiving MI tend to show more change relative to those given advice or treated with educational, didactic, or persuasive interventions. When MI is compared with other active treatment approaches, such as CBT, outcomes tend to be similar, though the MI treatment usually involves fewer sessions. Baber and Del Boca, 2003, Hodgins, Curry, and Elgabely, 2001, Marijuana Treatment Project Research Group, 2004, UCOT Research Team, 2005. Clinical effectiveness. Published studies tend to show significant positive effects of MI on behavior change under the highly controlled conditions of a randomized clinical trial, though there are also noteworthy examples of null findings. Example, Miller, Jan, and Tonigan, 2003. Efficacy trials, however, do not guarantee effectiveness when MI is applied by frontline clinicians under ordinary conditions of community practice with diverse populations. Ball, Martino, et al., 2007. Nevertheless, many studies have demonstrated significant clinical benefits of MI when delivered by frontline providers for problems such as alcohol. Example, Senft, Poland, Freeborn. 20 Motivational Interviewing in the Treatment of Psychological Problems. And Hollis, 1997, and Drug Abuse. Example, Bernstein et al., 2005, Marijuana Treatment Project Research Group, 2004, Hypertension. Example, Woolard et al., 1995, Smoking. Example, Heckman et al., 2010, and Health Promotion. Example, Resnico et al., 2001, Thevos, Quick, and Yangeli, 2000. Several aspects of the clinical trial literature are also encouraging in regard to generalizability. MI has shown efficacy across a wide range of target problems. populations, providers, and nations. U.S. studies of MI with ethnic minority populations have shown, on average, substantially larger effects than those with primarily white Anglo-American populations, Hatima et al., 2005. MI may offer advantages in cross-cultural counseling, particularly because of the therapist's focus on understand the client's unique context and perspective. Furthermore, studies in which clinicians delivered manual-guided MI showed smaller effects than those observed when MI did not follow the constrained guidelines of a manual, Hatima et al., 2005. This finding is consistent with an emphasis on the overall approach, or spirit of MI rather than on specific techniques, and overly prescriptive manuals run the risk of decrease therapist flexibility in a way that disadvantages effective use of the method. In any event, across multiple trials these findings indicate that MI is applicable to a range of populations and problems, and does not require the structure of a procedural manual and adherence monitoring. Nevertheless, adequate training is needed for clinicians to be able to deliver MI with sufficient fidelity to impact client outcomes. Miller and Rolnick, 2014. Why does MI work? When the effectiveness of a therapy varies across providers and programs, it suggests the need to understand the critical elements that contribute to its effects. One component of MI regarded by its co-developers, Miller, 1983, Miller and Rolnick, 1991, as central to its efficacy is the therapist quality of accurate empathy, Rogers, 1959, Truax and Kharkiv, 1967. Sometimes misunderstood as having had similar life experiences, accurate empathy actually refers to a learnable clinical skill for identify and reflecting the client's own experiencing. In research preceding the introduction of MI, therapist interpersonal skill in this domain predict subsequent client change, Miller, Taylor, and West, 1980, Truax and Kharkiv, 1967, Valle, 1981. As practiced within MI, accurate empathy blends with other interpersonal skill components to constitute an underlying MI spirit, assessed. Learning, applying, and extending MI 21. By Global Ratings of Clinician, Client Interactions, Bear et al., 2004, Miller and Mount, 2001, Moyers, Martin, Catley, Harris, and Alawalia, 2003, Moyers, Martin, Manuel, Hendrickson, and Miller, 2005. Observers' ratings of clinicians on this global scale predict more favorable client responses during an MI session, Moyers, Miller, and Hendrickson, 2005. Thus, one important component of the impact of MI appears to be the quality of the therapeutic relationship, reflected particularly in the skill of accurate empathy, Moyers and Miller, 2013. Miller, 1983, further hypothesized that MI would work by cause clients to verbalize their own arguments for change. Client ambivalence is resolved in the direction of change as clients express aloud the disadvantages of the status quo, the advantages of change, and their ability and intentions to change, Miller and Rolnick, 1991. Such CLIANT statements are now called change talk, and the strategic eliciting of client change talk differentiates MI from more general client-centered counseling, Miller and Rolnick, 2013. A wide range of studies has now confirmed a relationship between change talk expressed by clients during MI sessions and subsequent behavior change, Amrine et al., 2003, Bertholet et al., 2010, Gom et al., 2010, Hendrickson et al., 2004, Moyers et al., 2007, 2009. In contrast, client speech that defends the status quo, sustained talk, predicts a lack of subsequent change, Amrine et al., 2003, Miller, Bainey Field, and Tony Gahn, 1993. The more a client argues against change, the less likely it is to happen. This is not particularly surprising in itself. Resistant clients don't change. The implications for practice come from findings that client resistance is strongly influenced by the clinician's counseling style, Miller, Benefield, and Tony Gahn, 1993, Patterson and Forgach, 1985. An important part of the impact of MI training may be to decrease counselors' countertherapeutic responses that evoke SUS. Tane talk and discord associated with poor outcomes, White and Miller. 2007. Much remains to be learned about the mechanisms underlying the efficacy of MI. Our current understanding of how MI works is this. If the clinician counsels in a way that elicits client defensiveness and SUS Tane talk, change is unlikely to follow. If, on the other hand, the clinician provides accurate empathy and counsels in a way that evokes clients' own motivations for and commitment to change, then behavior change often follows. A more complex question would be why or under what conditions does change talk lead to change? Is change talk itself causal, or does it simply reflect some underlying process that leads to change? Simply. 22. Motivational interviewing in the treatment of psychological problems. Reading, writing, or chanting change talk seems unlikely to affect change. Neural activation patterns during spontaneous change talk are quite different from those with artificially induced change talk. Feldstein, Ewing, Philby, Sabanini, Chandler, and Hutchinson, 2011. Are there clients for whom MI is particularly indicated or contraindicated? Here the evidence base is thin, but a trend is apparent. The more resistant, oppositional, angry, a client, the greater seems to be the advantage of MI relative to more prescriptive approaches. Carnot and Longabaugh, 2004, 2005, Project Match Research Group, 1997. MI was specifically developed for clients who are ambivalent and less ready to proceed with change. Conversely, MI has been found to be unhelpful for people who have already decided to change. Within the new four-process model of MI, Miller and Rolnick, 2013, it is the evoking process that is unnecessary if a client is already prepared for change and the appropriate method, with adequate engaging, would be to proceed to planning. Continuing to use evoking with clients who are already highly motivated may damage therapeutic rapport or even lead to dropout because therapist and client are not on the same page. How do clinicians learn MI? Understanding how and why a treatment method works is helpful in knowing how to help clinicians learn it. This section focuses on what is known about how counselors learn the method of MI. 8 skills in learning MI. Miller and Moyers, 2006, have described 8 skills by which clinicians acquire proficiency in MI. The first of these involves at least openness to the underlying assumptions and spirit of the method, a collaborative rather than prescriptive approach, eliciting motivation from the client rather than trying to install it, and honoring client autonomy rather than taking a more authoritarian or confrontational stance. Internalization of this overall spirit increases with practice, but one is unlikely to learn MI, or want to, without first being willing to entertain the feasibility of this approach. Learning MI is, in our experience, particularly difficult for those with a directive expert perspective on the helping process. At the University of Arizona, Arkowitz has taught a semester-long MI practicum for students primarily trained in the directive style of cognitive behavioral therapy. At first, MI seems to students like not doing anything useful. As their skill in MI progresses, however, the evidence learning, applying, and extending MI 23 of client changes usually convinces them that they are indeed doing something therapeutic with MI. A next task, and a challenging one in itself, is to develop proficiency in the interpersonal skills of client-centered counseling, particularly accurate empathy. A skillful clinician makes reflective listening look easy, but it is a proficiency that is developed and honed over years of practice. To take the next steps in MI, the clinician needs skill and comfort in forming accurate reflections that move the client forward, encouraging continued exploration. MI differs from client-centered counseling in the focus of MI on ambivalence, and in particular on change talk. A third skill in learning MI, then, is for the counselor to learn to recognize change talk when hearing it, and to distinguish it from other forms of client speech. Being able to recognize change talk, the clinician next learns how to elicit and CIT and reinforce it. In other words, the counselor employs specific strategies to evoke change talk and responds differentially in order to increase and strengthen it. This is linked to a fifth skill, learning how to respond to sustained talk and discord so as not to increase it. The exploration of client ambivalence can continue almost indefinitely, and there is another skill in knowing when the client is ready to proceed to planning. Helping clients to formulate change plans represents a sixth skill in learning MI. Prematurely pursuing a change plan, however, can elicit pushback, increasing client commitment to the status quo. In MI, the change planning process continues to be one of collaborative negotiation. With a change plan developed, it remains to engage CLI and commitment to the plan, a seventh task in acquiring MI skillfulness. Finally, there is the skill of flexibly blending MI with other therapeutic methods. MI was never intended to be a comprehensive treat, meant displacing all others. In fact, some of its most consistent beneficial effects are in combination with other forms of treatment. Some counselors with a high level of skill in MI sometimes have difficulty switching back and forth flexibly with other styles when needed. Miller, Moyers, Arciniega, Ernst, and Forsheim's, 2005. Others find a way to blend the clinical style of MI with other therapeutic approaches, without a feeling of switching back and forth. Longabout et al., 2005. Initial training. From the above-described set of skills, it is apparent that there is only so much a practitioner could learn from a one-time workshop on MI. Even a 2 to 3 day initial workshop led by a proficient MI trainer is likely to provide primarily an introduction to the basic style and spirit of MI, first steps. 24 Motivational Interviewing in the Treatment of Psychological Problems. Toward learning reflective listening and an ability to recognize change talk. A workshop is not the means but rather the beginning of learning MI. Some ambitious learning goals for an introductory workshop are: 1. To understand the underlying spirit and approach of MI. 2. To recognize reflective listening responses and differentiate them from other counseling responses. 3. To be able to provide at least 50% reflective listening responses during a conversation. 4. To recognize change talk and be able to differentiate commitment language from other types of change talk. 5. To list and demonstrate several different strategies for eliciting client change talk. A workshop without follow-up, however, is unlikely to make a significant difference in practice. In an initial evaluation of Miller's own 2-day workshop, clinicians were able to demonstrate some skills on demand, but the changes in ongoing practice were minimal. Miller and Mount, 2001. More tellingly, there was no change in how clients responded to their therapists, example, change talk, after the workshop, suggesting no likely improvement in client outcomes. What does seem to help in initially learning MI is a combination of ongoing feedback and coaching. This is sensible in that these two components, personal feedback and performance coaching, are helpful in learning most any complex skill. To yield a significant gain in clinical skill in MI, an introductory workshop should be followed by some ongoing individual feedback and coaching based on observation of actual practice with clients. Miller, Jan, Moyers, Martinez, and Piri. Tano, 2004. Graduate training affords an opportunity for such ongoing shaping of clinical skillfulness. As mentioned earlier, the University of Arizona Clinical Psychology graduate program has offered a practicum on MI that involves lectures and discussion, demonstrations, role-play ING exercises, and ongoing supervision of clinical cases referred from the community. In a randomized trial of MI training strategies, therapists' clients showed increased change talk only when both feedback and coaching were provided after initial training. Amrine, Miller, Jan, Nupsky, and Hochstein, 2004. Continuing to learn. Excellent introductory training in MI, even with a few months of coach ING support, still constitutes only an introduction to the clinical method. Learning, applying, and extending MI 25. Imagine a 2-day workshop to learn psychoanalysis, tennis, piano, or chess. The real learning is in doing, and that requires ongoing practice with feedback. As it turns out, the needed feedback is built into the process of MI and depends upon knowing what to watch for. In response to a good reflective listening statement, the person keeps talking, reveals a bit more, explores a little further. The very process of reflective listening helps the counselor improve because clients continually provide immediate corrective feedback. In response to a reflection, a client basically says yes or no, yes, that's right, or no, that's not quite what I meant, and in either case tends to continue the story and elaborate. This is the kind of feedback that permits learning, just as reliable as CING, where the golf ball goes after a swing. Similarly, once one knows the sequence of client language in SUC. Successful MI, there is immediate feedback as to how sessions are going. Counselor responses that lead to change talk are the right stuff. In essence, client change talk becomes a reinforcer for counselor behavior. Counselors also learn what responses evoke sustained talk and discord. In essence, sustained talk or discord serves as an immediate signal not to repeat that response, but to try another approach. In this way, clients become your teachers, offering ongoing information much as archers receive immediate feedback after each arrow shot in target practice. There are other possible aids to continued learning of MI beyond the feedback provided by clients themselves. Computerized simulated encounters have been developed to which clinicians can generate responses and receive feedback. Example, Bear et al., 2012. Recording and listening to one's own sessions can be helpful, particularly when using a structured coding system to focus on particular processes within MI sessions. Lane et al., 2005, Madsen and Campbell, 2006, Pearson et al. 2007. Such session recordings can also be reviewed by a supervisor or coach whose task it is to help clinicians develop skill in MI. Some clinicians form peer learning groups to review session recordings together and discuss ongoing challenges in applying MI. Conclusions. In its relatively brief life, MI has already had a significant impact on both research and practice for helping people change. A large evidence base has accumulated supporting the efficacy of MI in addressing a number of problematic health and lifestyle behaviors. Much has been learned about how to help practitioners develop proficiency in MI. A puzzling 26 motivational interviewing in the treatment of psychological problems. Phenomenon is the high variability in efficacy across studies, sites, and therapists, suggesting a need to understand better what factors influence the effectiveness or ineffectiveness of MI. Miller and Rolnick, 2014. MI took root first in addiction treatment and medical health care. Applications of MI within mainstream mental health services, as reflected in this volume, is a newer enterprise. Studies continue to explore its utility with common clinical problems such as anxiety, depression, eating disorders, suicidality, and other issues that bring people to seek psychotherapy. MI has potential not only as a standalone treatment, but perhaps more importantly as an approach that can be combined or integrated with other effective therapeutic methods. A meta-analysis of treatments, primarily CBT, for depression and some anxiety disorders by Weston and Morrison, 2001, has revealed considerable efficacy, but with 1/2 to 2/3 of clients showing significant improvement. However, there is considerable room for improvement in treatment retention, reduction of problem severity, and prevention of recurrences. Using MI as a pre-treatment for CBT, example, Westra, Arkowitz, and Dozois, 2009, or delivering other evidence-based treatments such as CBT in the MI spirit, Arkowitz and Burke, 2008, Miller, 2004, both have the potential to improve upon these results. Some promising starts have been made to understand how and why MI facilitates change. Therapist empathy, client change talk, and diminutive IST resistance all seem to play a role in the efficacy of MI, but still we are just getting started in understanding the specific and relational elements that yield change. Miller and Rose, 2009. Research on the critical elements and processes within MI will continue to inform practice, quality assurance, and training of MI. Look how far we've come. How can we still have so far to go?